This is Malik Kahook from the University of Colorado. I'd like to thank the organizers for inviting me to speak. The topic of my talk is Going with the Flow, Optimizing IOP Control with the STREAMLINE System. These are my disclosures. So let's talk a little bit about what are the current options, and I think these are probably known to most of the people listening. We typically start off with an algorithm that includes a prostaglandin analog topical drop. This then typically moves on to laser trabeculoplasty, followed by some type of angle surgery, especially in the presence of a visually significant cataract. And then we start talking about filtration surgery like Zen, potentially PreserFlow if available, trabeculectomy express, and then drainage devices, of which there are many different versions on the market. And then typically cyclophotocoagulation is reserved for later stage disease. Now, a lot of this algorithm is evolving, and we know that oftentimes now we talk about using trabeculoplasty before drops even, especially with the light trial data that has come out over the last couple of years. We also know that cyclophotocoagulation, especially micropulse cyclophotocoagulation and endocyclophotocoagulation, can be used earlier in the treatment algorithm. So a lot of our teachings and the dogma of sort of starting with drops and ending with CPC is definitely transitioning as we speak. Now, I like showing this slide just because it gives a picture of how many different things we have available to us. It used to be that the right hand of the screen, filtration surgery and glaucoma drainage devices, was all we had when I was in fellowship about 20 years ago. But now the entire left side of this slide shows you what we have available to us with goniotomy, canaloplasty, and MIGS devices. The MIGS devices, as we term them on this slide, is really the implantables like the iStent Inject Hydrus, and the forthcoming MiniJect, which isn't available in our market, but is available in some markets around the world. So you can see that we have a lot of different options, and we can start sort of gearing these therapies to specific patients. But today I want to talk to you about one specific option, which is what I was asked to talk about today, and that's the STREAMLINE system. The STREAMLINE Surgical System, which is something that is on the market primarily in the US, put on the market by New World Medical, fits this idea of the definition of MIGS procedures. It's an ab interno approach. It's minimally traumatic. It's at least as efficacious as some of the other MIGS devices that we have, and some of the data are just now coming out, and I'll share some of that with you towards the end of this talk. Extremely high safety profile, which I think STREAMLINE definitely fits, and then rapid recovery. We think of the recovery of phaco-MIGS as being very similar to phaco alone. So what is the STREAMLINE Surgical System? Let's talk about some of the basics of the device, which I think is something that might be new to most of you in the audience. So let's start off by just showing you a picture of what the STREAMLINE Surgical System looks like. I'm going to use my arrow here to point at some of the important aspects, and then I'll show a video and animation that goes into a little bit more depth. So this is a handheld device with a port at the backside. This is the lure lock where viscoelastic can be attached, and either a cohesive or a dispersive viscoelastic, and you can read the label as to what has been tested with this device, is instilled into the device until you see some viscoelastic coming out of the tip. The tip is then introduced into the angle, and I'll show both animation and live recordings of the device being used. Once that's in place and abutting the trabecular meshwork, the button is then depressed and you'll see the action of the device. So let's show that in a little bit more detail. So I'm going to play this animation, and it has a voiceover, so I want you to take a look, and it goes over a little bit more detail of what I just discussed.
Introducing the STREAMLINE Surgical System, the new first-line implant-free solution from New World Medical. With the flexibility of multiple entry points, the STREAMLINE Surgical System creates precise and titratable incisions through the trabecular meshwork, or TM, with the capability of delivering viscoelastic into the eye. STREAMLINE can be used as a standalone procedure or in conjunction with cataract surgery. The STREAMLINE Surgical System consists of a surgical-grade stainless steel inner cutting cannula with a retractable outer sleeve and body that houses the system's innovative quick pulse technology. A Upon pressing the actuator button, the stainless steel cutting inner cannula creates a precise incision through the trabecular meshwork and delivers viscoelastic into the canal of Schlemm. To perform the procedure, first prime the STREAMLINE Surgical System. Confirm the patient's head is 45 degrees away from the surgeon and the angle of the microscope is 45 degrees toward the surgeon. Ensure a clear view of the anatomical structures, then insert the outer sleeve of the STREAMLINE Surgical System into the anterior chamber through an existing clear corneal incision, 1.8 millimeters or larger. Under direct gonioscopy, advance the STREAMLINE outer sleeve and locate the trabecular meshwork. With your hand stabilized, touch the outer sleeve against the trabecular meshwork to slightly applanate the TM without indenting the eye wall or losing view of anatomical structures. Activate STREAMLINE by fully depressing the button in one smooth, continuous motion to create the initial incision in the trabecular meshwork and dispense OVD. Pressing the actuator button initiates the quick pulse technology, which in one seamless step causes the outer sleeve to smoothly retract, creates a precise incision as the trabecular meshwork encounters the inner cutting cannula, and viscoelastic is delivered into the canal of Schlemm. With the button fully depressed, the position of the outer sleeve is maintained against the trabecular meshwork for approximately 2 seconds to fully dispense the OVD. It is important to maintain a constant position by not advancing or retracting the inner cannula and outer sleeve when delivering the viscoelastic fluid. Once the viscoelastic injection is complete, a titratable incisional goniotomy can be created with the inner cutting cannula of the device under the control of the surgeon and tailored to the needs of the patient. While maintaining the actuator button fully depressed and using the outer sleeve as a guide, the inner cutting cannula is directed to the left and right of the initial opening in the trabecular meshwork. This will result in an extension of the incisional goniotomy to the desired length. Additional quick pulse applications at least 1 clock hour apart and titratable goniotomies can be performed at the surgeon's discretion. With a single-handed, minimally invasive, implant-free approach, your surgical experience is more elegant than ever. With the STREAMLINE Surgical System, leave only your best work behind.
So I think an important aspect of that is you have a lot of choices with this device. You can create the puncture incisions, and you can do that over several clock hours and dispense viscoelastic over several clock hours. In the United States, if you're performing a canaloplasty, the goal for that is to do that over at least 90 degrees, where you're doing it over 3 different puncture incisions with injection of the viscoelastic. The definition for goniotomy in the US and similarly around the world is to perform at least a 90-degree incision or excision of tissue. So with STREAMLINE, you can do either or. You can do canaloplasty, you can do the goniotomy. In my hands, typically what we do with this device is the canaloplasty, where we do 3 different punctures at least, sometimes 5. We can do up to 8 punctures with this, and we inject viscoelastic over a broad area of the canal. There are other videos that are available online where you can see how far the viscoelastic goes, and we can get this viscoelastic to go 360 degrees, even when injecting just in the nasal angle, covering 90 degrees, 120 degrees. So there's a lot of flexibility, and you can tailor the therapy to the specific patient. We've done some basic science research here where we've injected tracer into cadaver eyes, and what we are seeing in this picture is an incision of the trabecular meshwork. So here's one of the leaflets, one of the sides of the TM, and then here's the other here. And again, this is very different than something like a KDB where you're excising tissue. In this case, you're just puncturing and creating an incision in the tissue. And then the viscoelastic with tracer was injected into the canal. We can even see it going into the collector channels, which was the goal of this device. You get a very broad distribution of the viscoelastic, and you also get viscoelastic going into the collector channels over a wide range, several degrees of the canal. This is anterior segment OCT, also to show a before and after. So this is the area of the canal prior to the injection, and you can see post-injection a dilation of the canal. This was seen in initial studies that were done over all of the patients that were treated, and it gave great comfort and illustration that the viscoelastic isn't just going in locally, but also distributing across the entire canal. So here's a treatment. This is Maziar Saburi performing this procedure. When you're looking at this video, I want you to pay attention to this side of the canal, and you'll actually see some of the blood, red blood cells moving along the canal when the viscoelastic is going in. So I'll play it here so you can take a look. So pushing on the button here, and you can see the viscoelastic going through. I'll play that one more time for you so you can get an idea of that. So take a look right over here. And you see that viscoelastic going, you can still see it going all the way to this side. And that gives you an idea of how much of the viscoelastic is going in. And you can repeat this 7 microliters of viscoelastic with each injection, with a total of 8 injections possible with this device. So I'm going to go to the next video, and this is just to show how the incisional goniotomy is done. Again, this isn't done with every case. I typically don't do it. I just do the canaloplasty procedure. But once the sleeve is retracted, you can use the inner cannula and slide it to the right and left and create a titrated goniotomy, incisional goniotomy, for as many clock hours as you desire. So let's talk about clinical data briefly. This is the first study that was published. This is a 6-month study that was done. I was one of the co-authors on this. This was looking at a patient population, 20 subjects with mild to severe primary open-angle glaucoma. And as you can see from a subject standpoint, 40% had mild, 40% had moderate, 20% had severe glaucoma. And they were treated with the STREAMLINE device with a puncture of the trabecular meshwork and injection of viscoelastic over an area greater than 90 degrees of the canal. You can see just the demographic data from an age standpoint, 64. The majority of these patients were female. 100% of these patients were Hispanic. And you can see the number of drops that they were on and the glaucoma severity again. So what we were able to show in this initial study was a significant decrease in intraocular pressure across the board, as well as a significant decrease in dependence on medications, with a decrease in their pre-op medications up to that 6 month of follow-up. But of course, 6 months of follow-up is relatively short. And what we followed up this study with is a 12-month look at the data. So this is in a patient population of mild to moderate primary open-angle glaucoma that were followed for 12 months. The unmedicated baseline intraocular pressure was 23.2. At month 12, 80% of all eyes and almost 78% of medication-free eyes had IOP reduction of greater than 20% from the unmedicated baseline. And 51.4% of the eyes were medication-free. And it's just to show you that the majority of the patients were off of medication, and the overwhelming majority of these patients had a significant decrease in their pressure of 20% or greater up to 12 months of follow-up. Longer-term follow-up is about to be published, so I'm excited to see some of that data coming out. You might be wondering sort of how I use this in my practice. I typically use STREAMLINE for mild primary open-angle glaucoma. So in my case, it's a replacement for a patient that might typically get an eye stent or a hydrus. For patients who have moderate or more advanced disease, they typically get a KDB goniotomy with excision of the trabecular meshwork. And then as we move forward with more severe disease, and after those patients have failed MIGS surgery, and as we know, with glaucoma patients, we typically are just trying to buy time, and a lot of these patients eventually progress. In those cases, I'll do a trabeculectomy or a glaucoma drainage device using typically in my practice an AGV or a clear path tube. So we have many options, and I think that's the exciting thing about being in glaucoma today. We know we have many options to treat glaucoma across a wide range of disease, and we're no longer talking about specific therapies for mild, moderate, or severe. We can really mix and match, and we can also do standalone or combined with phaco. New options like STREAMLINE will increase our ability to tailor the therapy. So it's kind of like looking at IOLs and doing a monofocal, a toric, a multifocal, and EDOF lens. We're really matching to the patient's needs. We're starting to do that, and it's really the expectation to do that with glaucoma now. We really need to match the specific approach to the specific needs of the patient. Increasing options in the implant-free category is a clear trend, and I think that's what we're moving towards. And the big question now is, what will the future bring? What are we going to be talking about in a year, 2 years, 5 years, 10 years? And I think it's going to be more combination therapy. It'll be phaco plus MIGS. And in the future, I think we're going to talk a lot more about drug delivery and how we can combine extended drug delivery with some of the therapeutics that we've used in clinic, but delivering it in a slightly different way. And also looking at refining some of the MIGS approaches and looking at multiple generations of the MIGS devices that we're using right now. It's a super exciting time to be in glaucoma. I'm happy to share this short talk with you. Hopefully, the Streamline information was useful. I know it's probably new to many of you in the audience. Thanks again for the invitation.